So, dear Chair, dear ladies and gentlemen, it's a great pleasure to speak to you at this prestigious course. And I will go through the needs of a radiation oncologist for imaging. So it's easy, and probably you've heard it. Just tell us where the tumor is, and that would us make very happy. Because the aim of treatment of localized prostate cancer is to cure patients and to cure them with minimal side effects, of course. So what do we need for that? So we would like to know the position of the tumor within the gland. Is it probably even a focal disease? We would like to know the extent of the tumor, tumor activity, grading. Is there any biological signaling you could tell us we have to focus on, maybe give more dose? And what about the lymph nodes? This will define technique, dose, and treatment field size of modern radiation oncology. So the radiation oncologist has moved from the 2D world, where we base our knowledge on anatomical landmarks on the patient, into the 3D world, using imaging, and even now 4D, where we use the time. And basically, what we see is what we treat. And probably using different imaging modalities, the same things look different. And probably we all know that actually, in the real, there is much more information deep down which we would like to know, which would define even better our treatment, maybe on the sub-millimeter base. And then the next problem we have, is it actually true what we see? You all see here, this is not an apple, but it's an image of an apple. So we as radiation oncologists, we rely heavily on imaging, and we want to know what we see, is it actually true? And when we see a prostate or we treat the prostate, we never see the prostate, we see the image. Basically, we see the surrogate. And if the machine doesn't work properly, we probably might do wrong treatment. And you know there is distortion and deformation, which also has to be taken into account for actually designing our treatment. And then we have, the prostate is moving. We have a moving target. It's not a static element. So when we do the imaging and we treat the patient later on, things have changed, and we have to take that into account as well in our treatment planning. So what I want to talk to you today is about treatment planning for localized prostate cancer. Then I will focus my talk on MR imaging in treatment planning and delivery, and have a little outlook. I do acknowledge the importance of PET and PET-CT, but however, in sake of time, I will not focus on that modality. Please excuse. So what are the challenges for prostate irradiation? Well, we know high dose gives better tumor control. That has been proven in randomized trials. We know also when we give higher dose, we have more toxicity, so we have to reduce our margins. And probably that's the concept radiation oncologists work. We have our gross tumor volume, which is the prostate, basically the lesion. Then we have the clinical target volume. Normally that's the prostate, because nowadays we don't really know where all the micro foci are in the prostate. And then we have the so-called planning target volume, where we actually add a safety margin so we do not miss any tumor due of organ motion during treatment. The other interesting concept that is now evolving is high dose per fraction. We call it hypofractionation, where we give higher than 2-grade doses per fraction. That will shorten the treatment time immensely. And also we do ablative radiotherapy, where we go up to doses of 9, 10, 21 gray per fraction, so radiosurgery. For prostate cancer, this is still in the experimental phase, but we will see that coming in the next years. So at the moment, we do CT-based treatment planning. That's the current practice. CT has increased immensely accuracy and reliability for radiation therapy. but you know better than me the limitations. Soft tissue boundaries are not well defined, and there is this partial volume averaging effect we are dealing with when we go through our transaxial slices to contour the tumor. And CT is known that it's overestimating the volume of the prostate. You can see these three studies up here. They look in the primary setting where you can see when you add MRI, or you would do your contours on the MRI, you see there is a significant difference in volume, so with your MRI you get much more precise. In the post-op setting, it's a similar situation. So you see that MRI is a very important tool. And then when you do CT and you ask experts from all the world, what's the prostate? That's what you're ending up, you know. There's quite an agreement in the mid-gland. When it comes to the base or the apex, things are changing. So this gives us a pain in the neck. And it's very important for treatment planning to actually accurately design the prostate. In our research group at the University of Zurich, we looked into that, and we found that because of the errors you do in contouring, you have to add these margins for compensating for the contouring errors. However, it might be only a few millimeters, but if you go to high doses, then 3 millimeters to the posterior side where the anterior rectal wall is high, and then you get proctitis. So for us, it's very important that we can keep the margins as tight as possible. In the study we did in Switzerland from the ACKK, where we treated post-op patients in a randomized fashion to a higher dose, 70 versus 64 gray, we could also show that based on CT, even when you do dummy runs and you exercise, the kappa value, when you did the initial, then the after review, so the learning curve is not that great with CT. There is still some debate what's actually the tumor in a post-op setting. So also there is need for and room for improvement. So radiologists have thought hard about how to improve probably the use of CT, but this gentleman looks rather uncomfortable, and I don't know if that really gives you better imaging of your prostate. So that's why probably using MR is quite a good idea. And you can see, and that's, I think you all know the beauty of MRI. You know, suddenly we see the base, we see the apex, and for the excellent visibility of the prostate anatomy is so much more, is so important for us to know. And what about extension of extracapsular disease? You know, based on the CT, it's very hard to see that probably here the cancer has already left the capsule. So if we plan our treatment based on the MR, we can actually know that with the margin has here, we have to give a bigger margin on this side, so it's not too tight and we don't miss. And then what happens if you add now multiparametric MRI, and you know that the sensitivity and specificity, it's increasing again. And with the diffusion weighted combined with T2 weighted MRI, we know that lower ADC is actually tells us where maybe the cancer is, and we can even differentiate from benign disease. We have a higher spatial resolution and obviously a better detection of significant cancer than with T2 MRI alone. So these new multiparametric modalities are also gaining now more and more momentum in our profession. Similar with the seminal vesicles involvement, you can see you can just much more better detect the extent of tumor, which also is important. Maybe we have to put up the field like here so we don't miss the seminal vesicles because the cancer otherwise recurs up there. Again, adding the new multiparametric modalities just increases your specificity and your accuracy in detecting the cancer in the area of the seminal vesicles. So very helpful. What about pelvic lymph node? This is a major prognostic factor and is decisive for treatment planning. MR lymphography, that's a hot topic as well, I think also in your societies. And you probably have all heard of these nanoparticles. They so far haven't made it into clinic. But there has been a paper in 2003 which actually could show that the sensitivity is increasing using these nanoparticles compared to conventional MRI. And if you combine it even with the diffusion weighted, you probably, it's a small series, you probably do not better in terms of accuracy, but you speed up your time in detecting these lymph nodes, which could be of advantage using all these new technologies. And I think this is very illustrative, and so we could actually design our treatments much more accurate. You see on this combined image that the benign lymph node is fully loaded with iron, so there are no tumors, no tumor cells in there. But however, these two probably they have loaded with tumor cells, and that has been proven by histology. So actually, our treatment field would probably focus much more on these lymph nodes and not on this one. However, this is probably the largest one. So that's a very smart and efficient way to dose escalate our treatments without adding too much more side effects. What about recurrence after surgery? We know also that up to 40% experience recurrence after radical prostatectomy. So precise localization of local recurrence is crucial for radiation therapy dose. However, it's difficult to detect. And this paper very nicely looked into that when you combine, again, the contrast-enhanced MRI with T2-weighted MRI, and you have a less experienced treat, and here you have an experienced treat, for both the sensitivity is increasing. Probably for the experienced one, the specificity is not that much better. However, for the less experienced, and the agreement between the readers using the combined technology just goes up. So that's also something which is important to know where actually the tumor is located to treat. Here, for instance, in the area of the anastomosis, the recurrent disease. What we use the MR at the moment is also doing co-registration. You know, we get superior definition of the apex. That probably means we can be careful with our dose. For the vascular structure, this may impact on the sexual function of these men, and without compromising the target coverage. Imagine a patient with bilateral hip prosthesis. It's very hard to contour the prostate. There are programs now compensating for these artifacts. However, when you combine it with an MRI, you actually can contour very nicely your prostate, and this also has been shown that actually the volume of your prostate is much more accurate. So is there time to move completely to the MRI without actually using the CT? Here you see the MR simulator. That was when I did my fellowship. The machine was 2 years installed, and we could use it. So I think we know that MRI is the modality of choice for imaging. However, the challenges for using MR for contouring is that different techniques have different sensitivities and specificities. So there is conflicting results about presence of tumor and boundary of tumor. So basically, to me, it seems a little bit unclear which voxels we should actually include in our contouring. And probably there is a practical approach. We could say all voxels that are identified and all imaging modalities we use, we would say that's the gross tumor volume, and the voxels we see on some of the multiparametric MRI modalities we would call the CTV, just to make sure we include everything. But this concept has to be proven further. So MR for treatment plan, at the moment, standard of care, the MR supplements CT data set. What are the challenges when you would use CT MR only? Well, as you know, there is no electron density for accurate dose calculation. We base our dose calculation on the Hounsfield units on the CT. So data registration is necessary. However, there are new treatment calculation algorithms called Monte Carlo who can deal with that kind of trouble. There is the distortion. The more away you are from isocenter, the more distorted is your image. And what about the optimal field strength? Well, that's in the literature. One use 1.5, the other is 3 Tesla. I think more the trend is now towards the 3 Tesla. Should we use the endorectal coil or not? That's also in debate. And if you use endorectal coils, you have to be aware of deformation. And as you can see, one solution could be if you use software where you actually could use the deformation and your computer calculates the actual, subtracts the coil, and you get probably the same information as you would use the CT without the endorectal coil. So these tools, they also are making it now into clinics. About radiation treatment response. Well, if a PSA rises after radiation therapy, normally people try to do a prostate biopsy. It's still considered the gold standard. We all know there are false positive and false negative rate. However, thank God, multiparametric MRI can help as well. As you can see, that's just a list, and the more you combine the modalities, you get better sensitivity. However, you have to be aware of the limitations. So it's technically challenging. It's poor standardization, and also there are some functional changes made that are decreasing. Then, so looking a little bit into the future. So Theragnostic imaging, probably you have heard of Theragnostic. That's basically a new way of looking at treatment while using the images to decide both where and how to deliver radiation therapy in an individual case. And functional and multiparametric MRI is actually helping us to doing that. We can do dose painting. So we would actually modulating the dose in space to match the variation in radiation sensitivity in the tumor. That would lead us to new ways, let's say MR-guided adaptive external beam radiation therapy, MR-adapted brachytherapy, and even proton therapy, which they like to use the MR as well. And that this works, and this has been shown in many papers in the preclinical setting, that actually your actual tumor fits very well with the actually ADC map, and so you would know that probably you have a prostate cancer, the high-risk area is here, so you would focus your dose on that area much more than on probably this side where you probably would only give your low dose. And this is actually now happening into clinic, and our colleagues from the Netherlands, they are pursuing this avenue doing this FLAME trial where they actually use the multiparametric information. They give 76 to 77 gray to the whole gland in IMRT technique, and then they do a GTV boost of up to 95 gray. So this is, like Professor Sulzer mentioned, the focal approach, which will be also happening in radiation. And then we have this new thing which is called the MR linac. So also the same group in Utrecht, they're actually developing an MRI combination of a linac. It's still a prototype, and there is a lot of technical issues to solve, but I think eventually this machine will be the next generation of linear accelerators we will have to install and to use, and you could actually use these images to do your treatment. And this machine is actually in Harvard University. This is actually clinically used, the MR cobalt. So they have 3 cobalt sources. It's actually then combined, and you can do all the nice things we like. You have excellent visibility. You can do tracking. You can do 4D, the motion control, and also they base their algorithms to planning on the Monte Carlo system. We'll see if these machines will be more successful. They are at the moment more in the stage of studies, but I'm sure in a few years from now we will see this much more. So that's probably the vision. I would say that we will move to real-time adaptive MR image-guided oncological interventions. You know, this should improve local control for prostate cancer. It's non-invasive, and we can even assess treatment response and plan our re-interventions. So, it's a long time ago since this man started, and probably that's why we're all here. And we all took probably different avenues, radiation, oncologists, radiologists, nuclear medicines. But now I think it's the time things come together, and I think in the sake of our patient, it's very important that we move together ahead. Thank you very much.